Good afternoon, everyone. We're so glad you could join us today for our iSpark webinar, Moving from Trauma-Informed Care to Trauma-Responsive Care Through Training, Referral, and Treatment for Youth and Families, featuring Drs. Jessica L. Griffin and Zlatina Kostova. Before I turn it over to them, I'm going to just go over a few housekeeping items. Could you move the slide forward, please? Thank you. My name is Dee Logan, and I'm a project associate here at UMass Medical School's iSpark. If you have any technical difficulties, you'd email me at deirdre.logan@umassmed.edu, or you can use the questions tab in GoToWebinar. Just so that you know, this webinar is being recorded, and the recording as well as the slides will be made available on iSpark's website. If you're calling in over the phone, please use your unique audio PIN. If you have any handheld electronic devices, we recommend you move them away from your computer and speakers if that's the way you're listening. We also recommend that you close any file sharing applications, streaming music or video. If you are experiencing any audio problems, please check your settings in the audio tab in the GoToWebinar dashboard. And we will be having a Q&A session after the presentation. It'll be moderated. So if you have questions, you'll be typing them in for the presenters, and you can type them in at any time during the broadcast, or you can type them in at the end, whichever works best for you. And with that, I'm going to turn it over to Drs. Griffin and Kostova. Thank you very much.
Great, thank you, Dee, and welcome everyone. We are thrilled to be here. Thank you to the folks at Spark for having Zlatina and myself come and speak to everyone today. So very briefly, my name is Jessica Griffin. I'm a psychologist here at UMass. I've been here for about 15 years, I think, and I'm the executive director of the Child Trauma Training Center here. And Zlatina?
Hello, everyone. My name is Zlatina Kostova, and I'm a postdoctoral fellow. I work at the Child Trauma Training Center with Jessica, and I've been specializing in childhood trauma in the last 4 years, basically. So the agenda of today, we will start with introducing what is childhood trauma and what are the impacts of trauma on child's development, and also identifying what are some of the needs and gaps that we still have in our services in serving children and families who are impacted by trauma. Then we will talk about our Child Trauma Training Center and talk about how with our goals and the activities that we are doing here, how we are meeting those needs and gaps in trauma services. Then we will talk about trauma-focused cognitive behavioral therapy, which is the treatment that we are implementing in our center, and we will also present some of our research data. We have been doing a research project from our previous grant cycle, so we'll be presenting some of the outcomes that we found out. And then we will conclude with some practical implications, talking about some of the challenges that we had in implementing trauma-informed services, and also sharing some of the next steps and how we are thinking to meet these challenges. So statistics about the prevalence of trauma are really staggering. And when we say that childhood trauma is a major public health issue, this is really true. There are 35 million children in the U.S. who are experiencing at least one type of trauma by their 8th birthday. And unfortunately, when we see children in clinical settings, it's really rare to see a child presenting with only one type of single trauma. And actually, research is showing that 1 in 9 children have experienced at least 3 adverse childhood experiences. And we know from this research study that the higher is the number of traumatic events, the higher are the risks of developing a lot of mental and physical health problems. We also know that trauma is different across different races and ethnicities. So there are 61% of Black non-Hispanic kids who have experienced at least one type of trauma, followed by Hispanic, then 40% white, and then 23% Asian. And when we look at our local data in Massachusetts, actually looking at our own research data, they're showing that children here experience a mean of 4.4 traumatic events. The most common traumas are domestic violence, traumatic loss, physical abuse, sexual abuse, and also community violence. And even though there are a lot of great projects and trauma initiatives in Massachusetts, there is still a huge demand to improve access to services. So we know that the impact of trauma is deleterious on a lot of different areas of child development. So children who have been going through trauma, they may present with a lot of attachment problems. They usually have a lot of uncertainty about the predictability of the world. They may lack appropriate boundaries and have a lot of interpersonal difficulties. We also know that childhood trauma is impacting the biology of kids. A lot of them present with a lot of physical conditions or also general developmental problems. Kids with trauma also have difficulties in identifying what they feel and also finding the right coping strategies to regulate their emotions. Dissociation is also another factor that we observe in childhood trauma. So children may dissociate during the trauma, which is something that we call peritraumatic dissociation, or we can also observe symptoms of depersonalization or derealization after the trauma. We also know that kids with trauma has problems in controlling their behaviors. They might be more impulsive or engage in a lot of risky behaviors. The executive functioning of kids with trauma is also impacted, and therefore they might have more difficulties learning new information or using problem-solving skills. And last but not least, kids with trauma are lacking a sense of a continuous and predictable self. They usually have a very low self-esteem, and they experience a lot of feelings of shame and guilt. So clearly, childhood trauma is a public health crisis, and it's a growing problem not only in the U.S. but also beyond. And I'm coming from Europe, so I know that there are also a lot of European countries that are trying to implement trauma-informed care. And trauma does impact the development of children, but also their brain structure and DNA, impacting also future generations. Nevertheless, when we look at the reality, we know that children and families who have experienced some traumatic events, 47% never received any services. And sometimes children may wait between 6 and 12 months to access mental health services, especially in community settings. And so still, there is a clear gap in our ability as professionals to identify trauma, to make an appropriate referral, and also to provide trauma-informed treatment. There are not enough clinicians who are actually trained and certified in evidence-based trauma-informed treatment. And so this is why we created our Child Trauma Training Center, and I will pass the floor to Dr. Griffin.
All right, thank you. And so I'm just going to talk briefly about the development of the Child Trauma Training Center. We were initially funded from a grant through the Substance Abuse and Mental Health Services Administration, SAMHSA, through the National Child Traumatic Stress Network, beginning in 2012, and we were refunded in 2016. For those who are not familiar with NCTSN, I want to put a plug in for them as a terrific resource for families, for providers, for educators, for anyone who's working with kids and older adolescents and transition age youth who've experienced trauma in their families. If you go to nctsn.org, there's a plethora of resources and materials, from webinars and videos to fact sheets to coloring books, all designed to help kids who've experienced trauma. And and align with the mission of the NCTSN, which is really to raise the standard of care for youth and families who've experienced trauma across the country. So we have three major priorities for our center, and we do a lot of different things here, but they tend to fall into these three main areas. And the first is to provide trauma-informed and trauma-responsive training across professional groups. So any groups that are intersecting with kids, we're trying to provide trauma training for those groups in a way that meets the need of that particular audience. So for example, we've done a lot of law enforcement training, but before we even rolled that out, we were doing ride-alongs with police officers to try to get a sense of what the job looked like from day to day. So we really try to get to know each professional group and what would work for them. But we're trying to provide training across those groups for any professional who's interacting with kids on a regular basis. The second priority was to create a neutral centralized referral system called Link Kid, which I'll talk about here in a moment. But the idea behind Link Kid is to expedite kids who've experienced trauma into appropriate evidence-based treatments for them to try to deal with the waitlist issue that so many of us and so many of you listening to this webinar are very familiar with. Kids are waiting. When we did a survey of mental health agencies, they were waiting an average of 6 to 9 months, sometimes more than 12 months for that first therapy appointment. And then the last thing that we're doing through our center and have been doing is training in trauma-focused cognitive behavioral therapy. And we do a learning collaborative in TF-CBT every year, which is followed by a year of intensive consultation for clinicians to try to increase the number of TF-CBT providers in the workforce. So briefly here, Link Kid, as I mentioned before, is our referral system. And the idea is that we're not tied to any particular mental health agency, but a network of providers who've been trained in various evidence-based practices, specifically focused on trauma. Currently, and this has grown over the years, we're staffed by 4 clinical resource and referral coordinators who've all been trained in trauma-informed care and practices, many of them trained clinicians in various evidence-based treatments for trauma. As part of Link Kid, we incorporate family engagement strategies, evidence-based family engagement strategies, and have a very large database now of providers who've been trained in various evidence-based treatments for trauma. We started locally in our first grant cycle. We were focused on Worcester and Hampden counties, but we are now statewide, and Link Kid is a statewide resource. So anyone can call us, whether you're a parent, a provider, pediatrician, guidance counselor, to make a referral, and our goal is to get kids into treatment as fast as possible. So we track wait lists at different agencies, whether it's a community agency or even individual practitioner practicing in private practice. We track who takes what insurance, who speaks what language, and try to match the child and family to a clinician who would be a good fit for them, and in order to cut down on the wait time that kids are experiencing. So we make referrals to up to age 25, so to capture transition age youth population, to trauma-focused CBT, the ARC model, child-parent psychotherapy, parent-child interaction therapy, and other trauma-specific treatments. So we could not have gotten to where we are now without a lot of work and, frankly, a lot of relationships that we developed over time. And with that said, I don't have a slide for this, but just wanted to give a shout out to a number of our partners, and I'll just start with our staff and faculty here. Genevieve Cainhouse, who's not on this webinar, is our project director, and we could not do this without her or her predecessor, who is Tony Ersfeld, and many of you may know Tony as well. Heather Forkey, who's a pediatrician, is our partner in crime here and helps handle all the medical side of the training that we offer. Jessica Dim-Bartlett is now at Child Trends, who provides all of our project evaluation, and we have a number of referral coordinators, Deanna Rinker, Sarah Dudek, Elizabeth Lawson, and Zlatina Kostova, who you're hearing from today, as well as our administrative assistant, Laurel Post, and Laurel's been with us for, actually since I've been here at UMass. So I want to give a shout out to those folks, but also to our partners across the system, including Bay State Family Advocacy Program, we first piloted this with the DA, Joseph Early in Worcester County and their Children's Advocacy Center there, but now are strong partners with the Massachusetts Children's Alliance and training CACs across the state. The Child Protection Program and FACES Clinic here at UMass that Heather Forkey runs. Spectrum Healthcare around our substance abuse initiatives, school-based health centers, the American Academy of Pediatrics, DMH's CBH Knowledge Center, and many of you know Kelly English, who's been a strong partner of ours, the trial court, the probation department, Department of Youth Services, Department of Children and Families, Department of Mental Health, Department of Public Health, the Family Resource Centers, Committee for Public Counsel Services, and PAL, the Parent Professional Advocacy League. So we could not have gotten to where we are now. And I know there are others that I'm missing as well, including our mental health partners, Family Continuity Program, LUC, UINC, Community Health Link, MSPCC, Judge Baker Children's Center, and the Bridge of Central Mass. But there are so many others who have helped us along the way, and we are forever grateful for that because we could not have gotten to where we are now. With that said, we had our first learning collaborative back in 2006, and this is the first time that trauma-focused CBT was imported into the region, was 2006, and we trained about 80 clinicians then, and those are really the veterans in TF-CBT. A few years later, we partnered with LUC to develop the Central Mass Child Trauma Center, which was another National Child Traumatic Stress Network grant. And then in 2012, we went out on our own and established the UMass Child Trauma Training Center. So that was the original iteration of our program now. Over the years, we sought additional funding. The Lookout Foundation helped us pilot a statewide rollout, and we did that in a stepwise fashion, focusing on a different region each year. We then received a grant from DMH for that trauma referral service, and that helps to support our Link Kid program. We were refunded, as I mentioned earlier, in 2016. And then, as I said, we expanded in a stepwise way, which we think was really important in trying not to go totally statewide at once. It was really important for us to develop partnerships and relationships with each region over time. Our original target population was kids ages 6 to 18, but we've been able to expand the age range down to 0, and then with additional funding up to age 25 with funding from the Lookout Foundation. And the idea, since 2006, we were trying really hard to work on helping professionals become trauma-informed. And what do we mean by that? There are so many different definitions out there of trauma-informed. We use the definition that the National Child Traumatic Stress Network has adopted, really emphasizing that collaborative approach. But trauma-informed is the knowledge of how trauma impacts kids, but also the piece that sometimes is missing is what are we going to do about it? All right, so we know that trauma can have an impact, but guess what? There are also so many youth who experience trauma and adversity that do pretty well and are more resilient. And so we're starting to really look at what are those resiliency factors and how can we make our population of kids in general more resilient in the event that they do experience trauma. As a psychologist myself, I'll be the first to say that mental health treatment works, and we have these terrific evidence-based treatments from trauma-focused CBT to many others that are very effective. I will also be the first to tell you that most kids, especially our priority populations, are not accessing those services, but they are seeing a teacher every day. They're seeing a daycare provider. They're seeing a police officer. They're seeing other people that they interact with on a daily basis. So part of our work is trying to train the workforce in how to be more trauma responsive, meaning what are we going to do about it? What are concrete strategies we can use to try to help children heal who've experienced trauma, but also increase their resilience? And so I'm going to shift here just briefly to introduce TF-CBT before Latina does an overview of our outcome data from the first iteration, but trauma-focused CBT is the most rigorously tested treatment for trauma to date in kids, with over 21 randomized controlled clinical trials. And what you want to see happen in that world is that it's not just the developers of the model that are actually testing their model, but other people are going out and replicating the model in different settings. And we have RCTs that have been done in the Netherlands, in Norway, and several African countries, Democratic Republic of Congo, in Zambia, in Japan. So it's being replicated with positive findings across the world. And of course, there are cultural modifications that are made depending on what group you're working with. But the model was developed by Judy Cohen, Tony Manarino, and Esther Deblinger, and has been refined over the last couple of decades. It's the most rigorously tested because it's also the one that's been around the longest, but it is considered the gold standard for treatment of childhood trauma to date. So you're able to use TF-CBT with kids as young as 3 up to age 18, although we are we are currently piloting in our center TF-CBT with transition age youth in conjunction with the support of the treatment developers. TF-CBT can be used for any type of trauma. It does not have to be a single traumatic event. It can be kids and youth with complex trauma, multiple traumatic experiences, layer upon layer of trauma. It can include traumatic grief, domestic violence, natural disasters, war, etc. It was originally developed, the index research studies were originally developed looking specifically at child sexual abuse. That's what got kids into those particular research studies. But even in those studies, the average number of types of trauma was 3.8. So these were still kids with multiple types of trauma. Youth need to have some sort of trauma-related symptoms or impact. They do not need to meet full criteria for PTSD, but some sort of trauma-related symptoms or impacts. Latina gave a nice overview of what those domains may be. It could be impairment in attachment or cognition, their own self-esteem, and so on. The parent involvement or caregiver involvement is optimal in the model, but it's not required. You can still go forward in the model without that piece. And it's been modified for use in a variety of different settings, from outpatient to inpatient, home-based, and other settings across the world. TF-CBT is both a components-based model and a phase-based model. So the components of TF-CBT are up here on the screen in our fancy acronym PRACTICE, and that those phases are on the right-hand side, from stabilization and skill building, trauma narration and processing, to consolidation and closure. So briefly, I'll talk us through the practice components here. But the first component is psychoeducation. We're providing information about trauma, including information that is specific to what that child has been exposed to. So we're giving information specific to sexual abuse, information specific to domestic violence, or historical trauma, depending on what the types of trauma are that this child has gone through. There's also the parenting skills component, which is a component we do throughout treatment and working closely with caregivers. The relaxation component is designed to turn down that hyperarousal that many youth experience who have been traumatized in some way, and to teach stress management skills. Affective regulation or affective modulation is we're teaching feelings identification and then how to express those more effectively. Cognitive coping is really the set of tools. This is where you're going to see those cognitive behavioral therapy principles come to life, but are they learning how their thoughts are connected to their feelings and connected to their behaviors? The next phase and next component is the trauma narration and processing component. And this is where kids tell their story about what they've gone through. What it could be in the form of a chapter book, it could be in the form of a rap song or a 3-act play, but it's their opportunity to tell their story, to make that unspeakable more speakable. And the idea is that we're doing gradual desensitization to what they've gone through and helping to put it in a larger context of their life. In vivo mastery of trauma reminders, that in vivo component is one we don't always do. It's with specific feared situations that kids may have, like fear of going to school, fear of going to the bathroom in a public restroom, those types of things. Conjoint child-parent sessions are those joint sessions where we bring kids together with their parents or caregivers, and they do the sharing of the trauma narrative if it's appropriate to do so. We have other joint sessions where we may do some family work around issues that are trauma-related. And then lastly, we're focusing on enhancing safety and future development for this child. And the components, although we typically do them in order. We do make modifications. So for youth with complex trauma and in other situations where it makes sense to do so, we start with safety. And we may even follow that with relaxation before we even get into psychoeducation. But we make modifications to the model based on the youth and family we're working with. And again, there is a tremendous amount of research support for TF-CBT. Those RCTs have been conducted all over the world. Just in a nutshell, when you compare TF-CBT to treatment as usual or other treatments, there's much greater improvements in post-traumatic stress symptoms, depression, anxiety, behavioral problems, and also things like abuse-related shame and guilt. We also see a greater increase in resiliency factors as well. Caregivers who participate also improve. So we see greater improvements in parental competence and confidence in their parenting abilities, decreases in parental depression, and decreases in parental stress related to trauma. And this is our map. It fell a little low here, where TF-CBT has been implemented, and a list of all of the countries and regions in which TF-CBT is currently being practiced. And with that said, I will turn it back to Zlatina to talk about some of our outcome data.
Thank you, Jessica, for this great introduction of TF-CBT and especially the internationality of this model. Unfortunately, I'm originally from Bulgaria. It's not yet there, but hopefully. So with the next slides, I'll talk about the general outcome data that we collected from our previous grant cycle between 2012 and 2016. And here we'll talk about what was the impact, what were the effects of TF-CBT on children and caregivers' outcomes. So the way that we did our study, basically, Dr. Griffin provided 3 annual year-long TF-CBT training cohorts involving in total 211 clinicians. And the training in TF-CBT, it's really great because, first of all, it starts with an online introduction of TF-CBT. Then clinicians are invited to a 2-day in-person basic training, followed by an advanced training where we talk more about how to adapt TF-CBT in specific populations and settings. And then clinicians are given the opportunity to participate in monthly consultation calls where they can basically bring their cases. And they receive feedback from experts in TF-CBT. So once a clinician is enrolled in our trainings, they're really well followed for an entire year, which is a great opportunity to really learn well the model and be part of a community. And then we ask each clinician to enroll at least 3 youth and implement TF-CBT with them, and they collect data at baseline, then at 3 or 6 months, depending on the cases, and then at discharge. What we are measuring is we are measuring the behavioral problems of children using the child behavior checklist. We measure PTSD symptoms using the UCLA PTSD scale. We are also interested in seeing any changes in the caregiver stress. We know that childhood trauma impacts the whole caregiving system, so we are measuring also caregiver strain and also the sense of social connectedness in children and parents. So our final sample was 308 children and youth. Their mean age was 11.3. They were equally distributed by gender. The majority of them were white. And I know that you can't probably see very well these slides, but this is basically showing all the different types of trauma that our kids experienced in our sample. And the most important information at this slide is really showing that the mean trauma of kids were 4.4, which is not a low number. And basically, some of the main types of trauma that children experienced was traumatic loss or bereavement, impaired caregiver, which we basically mean a caregiver who has problems of addiction or some severe mental health illness, emotional abuse, and also domestic violence. So this graph is showing the baseline PTSD symptoms among children. And the most important thing here is that the majority of our sample, the majority of the children, actually exceeded the clinical cutoff of PTSD symptoms. The clinical cutoff is 37, so anything above that is considered in the clinical range. And here you can see that actually our sample was pretty traumatized, especially in the cluster of re-experiencing and arousal, but also in the total severity. The majority of our kids experienced high levels of PTSD. We are not reporting here the graph of the caregivers, but it was something interesting actually that we found out, that caregivers had a different perception of PTSD symptoms in their kids, and they slightly underreported those symptoms. So this is an additional project that we are currently working, because it's been a pattern that we are seeing this difference in perception in PTSD symptoms between caregivers and children. And so we are trying to understand why is this difference, and if there are some specific types of trauma where these differences are more prominent. But this will be for our next presentation. Similar is the picture in behavioral problems. So according to parents, their children exceeded again the clinical cutoff of behavioral problems, particularly internalizing scores and total problem scores were pretty high. The externalizing behavioral problems just met the clinical cutoff, but also here we can see that at baseline, those kids were pretty high on behavioral problems. Now, what happened after TF-CBT? So basically, this graph is showing that actually TF-CBT significantly reduced children's PTSD problems. And we can see that that was pretty consistent among the different clusters of PTSD symptoms, and especially when we look at the total severity, there is a significant decrease, especially at discharge. And also this decrease in symptoms helped in narrowing the gap in the differences between children and caregivers, which is really important in helping also the caregivers to bring them up to the awareness of those symptoms and foster a relationship and communication. Similar is also with behavioral problems. TF-CBT significantly reduced the behavioral problems among children. Here the effect size were more small to moderate, but still a significant decrease in those problems. Children also significantly increased their sense of social connectedness after TF-CBT. So they felt more able to share their problems with their family members or friends, and they felt also more understood by their families after TF-CBT. Also among parents, there was a significant increase in their sense of social connectedness, even though, again, the effect size were more small to moderate. TF-CBT also helped parents to feel less stressed about the trauma of their child. And again, TF-CBT was very helpful in reducing stress in different types of domains. The only one type of stress that did not reach significance was externalized strain. So parents were still struggling with feelings of anger and resentment after TF-CBT, but overall they felt less stressed out. So in these slides, we basically saw that TF-CBT works, and it works pretty well. And specifically, TF-CBT was very helpful in reducing PTSD symptoms and behavioral problems. It helped kids to feel more connected to their social network, and it also reduced caregiver stress. So these were our data from our previous grant cycle. We are now collecting data from our new grant. And again, I will turn it now to Jessica, who will introduce you to some of the new data that we are collecting.
Okay, great. Thank you, Zlatina. And I think one of the things that we were most proud of with the last cohort was some of the resiliency factors, which this next cohort we're measuring even more so. But the social connectedness is one I think we were really happy to see that was increasing both for kids and families. And we know that when parents are doing better, kids are doing better too. And so our findings are consistent with the TF-CBT research, but in a more community setting here. Okay, so with that said, we have, this is as of our last quarter grant totals. So we had initially proposed that we would train 10,000 professionals and impact 250 youth with the services and training that we're offering. And I'm pleased to report today that we have trained over 16,000 professionals just in this last grant cycle and have impacted over 250,000 kids. So we've met those numbers and are now on a path to blow those out of the water, which is great. It also speaks to a need with the number of trainings that are still out there. We get calls on a fairly regular basis about different organizations and communities looking for training in trauma, which is wonderful, because 10 years ago or so we'd walk around saying, trauma-informed care, well, what is that? And now a lot of people are asking for it or doing that, and it says a lot about our community and the commitment to helping kids heal. Very briefly, Link Kid referrals, our Link Kid system, as we've expanded statewide, continues to grow. We have, as of year 2, we had 636 referrals, and just in our last quarter, we had over 200 in our last quarter. So we continue to grow as far as referrals go. The majority of referrals that we're making are to the TF-CBT model. Part of that is we have a lot more providers trained, and yet we still have wait lists and still have providers and agencies wanting more training and a need out there without the resources to be able to support a lot of these learning communities. We offer ours every year through the grant that we offer, but we know that we are still not meeting that need. And so briefly, as far as this last year or so, we completed our second learning community in April. We hosted our third learning community, prioritizing clinicians in Middlesex and Essex counties, although it was open to clinicians statewide. This last iteration, we trained 108 clinicians back in March and conducted a supervisor training and our beginning supervisor calls later in the fall. We have our advanced training coming up, and we have learned a lot over the years as far as what barriers to implementation are and how to address some of those, but we are continuing to learn, and every single year we're refining what it is that we're doing, and oftentimes it's based on feedback from people who may be even joining this call. So in conclusion, we know, and also consistent with the literature, that TF-CBT works, but it also works in settings like ours, where our priority population from the outset had been court-involved youth, kids with complex trauma, kids involved in multiple different systems. And so these are not youth who've experienced one trauma on one particular day, but layer upon layer of treatment. Kids who grew up in homes with chronic neglect and parental substance abuse, which, by the way, parental substance abuse makes around 40% of our referrals to Link Kid have parental substance abuse as one of the issues that they're struggling with in the family. So these are complexly traumatized kids, and we still have been able to show tremendous progress for kids in our care. We know we can both reduce maladaptive symptoms of trauma, but also increase resilience in youth and their families. So since the beginning of our program, we have now trained over 30,000 professionals in trauma-informed care and have impacted over 430,000 youth. That number is staggering to me, but it's a lot, and it's also been a lot of work and a lot of people involved in trying to make that happen. We've provided TF-CBT to over 1,500 children in our evaluation projects, and have over 3,000 active referrals that we've made through LinkKid, successfully made through LinkKid, to get kids access to treatment as fast as possible. But we do know that training clinicians implementing these treatments has its challenges, and we're continuing to learn from that. And so with that said, we are providing additional support to each of our mental health agencies that we're training in TF-CBT. We have now a coordinator who goes out and does site visits with our agencies, connecting with supervisors and clinicians, helping to augment some of the consultation that we do with clinicians on a regular basis and be clearer about expectations for being involved in our training cohorts. We collaborate statewide with children's advocacy centers across the state, and MACA, Mass Children's Alliance, is a strong partner with us. We're continuing to offer training in TF-CBT to children's advocacy centers. And then we train our providers, including providers who've been trained as long ago as 2006, in booster sessions in TF-CBT to train them up in how to modify the model for various groups, such as court-involved youth, transition-age youth, youth with developmental disabilities, and other populations. We have been piloting something called TF-CBT Prep, which is a shorter-term model that we're using to bridge families who are waiting for services into treatment, and we're piloting that through Heather Forkey's program. Genevieve Kane-House and some of our other faculty and staff are piloting that model with us, so we're taking a look at what that looks like, in addition to the pilot we're doing with transition-age youth. We have a very wonderful evaluation team at Child Trends that's helping with our project evaluation. We do use an external evaluator for that. Okay, so with that said, I know Zlatina and I had a goal of wanting to make sure we had plenty of time for questions. I imagine that there are many. Here is our contact information for those who want to reach out to us. But at this point, I will turn it back over to our facilitators to let us know what questions may be out there.
Thank you so much. Yes, we've had a few questions come in. And please feel free to type in questions as we're going through the ones we have now. The first question, so on Native American reservations and villages, the youth are exposed to more trauma annually, and the communities are experiencing increasing incidents of trauma, neglect, and abuse. Have you ever provided TF-CBT in Native American reservations and villages, or do you have any data concerning American Indian or Alaskan Native children's exposure and ACEs?
Okay, this is a terrific question, and we could not agree with you more. There is actually a group within the National Child Traumatic Stress Network that focuses on working with Native American families, and there's a modification of trauma-focused CBT specifically for use with Native American families. And we have been, I have identified that there actually was some funding. We did not receive it, but we were looking to do a lot of what we're doing specifically focusing on Native American families, and are open to being able to do that and partner with groups to provide some of that training and support. But yes, we are familiar with the very high rates of trauma in that population, and being very underserved population, and so would love to partner with folks on that. But there is data on the high rates of trauma, and ACEs, yes, but beyond ACEs. I mean, the ACE study is a terrific longitudinal piece of research that looks at trauma in adults and histories of childhood trauma, but it only measures 10 different items or 9 different items, and does not capture community violence and impact of racism and historical trauma and lots of other types of traumatic experiences that people go through. So yes, their ACEs are very high, but there's also other types of trauma as well, and higher rates of poverty and parental substance abuse and so on. So terrific question. There's definitely a need, and folks want to reach out to us to talk more, feel free to email me or give me a call.
Thank you. Someone asked, earlier in the presentation, Dr. Kustova referenced regional data that showed children experiencing an average of about 4 socio-traumatic events. What region does this data cover?
So I can speak to that. So the region that she's speaking to was in our first cohort, which was Worcester and Hampden County specifically.
Okay, thank you. Someone was interested, and I don't know how much detail you can get into, but you might be able to refer to your website or something. But someone was interested in learning more about the family engagement aspect of the referral process, as well as the process content for engaging the families in TF-CBT.
Great. So there's a couple different things. So there, the family engagement strategies that we've adopted are Mary McKay's family engagement strategies. So you can, if folks want to email me, I can try to send you an article or two. There were some TF-CBT research studies. It started with the work that she did with Kimberly Hoagwood after 9/11 and around, connecting with families, making sure that you have some sort of nugget that you're offering in that first contact. That first contact is really critical. But there's a number of other strategies that she has found in her work that we've adopted. So connecting with families, what's in it for them, providing supportive materials. We do, as part of LinkKid, we do that hand-holding that families need until that referral happens. So even though we've been able to drastically reduce wait time for families from, as I mentioned earlier, 6 to 9 months, our last quarter, I think we were somewhere around 40-something days, which, as a mom, that's still too long for my child to wait for therapy. At the same time, it's much better than 6 to 9 months. And we do have some families that wait longer depending on what area they're in and so on and so forth. So it's Mary McKay's work that we use to integrate into both the TF-CBT family engagement piece, but also in our LinkKid referral and resource system that we have here. And I'm happy we can talk offline regarding what LinkKid looks like from when that phone call comes in to how that referral is made if anyone's interested. But those are the strategies we use.
Yes, and we will be having a written product coming out in the next month or two on the the LinkKid project, how it started, what it does. But they have some great information on the CTTC's website as well, which I can send out in a couple minutes.
Thanks, Dee.
So this is more of a comment, but I don't know if, but someone had said, I would venture that parents underperceive trauma symptoms in their children if when they are not in touch, quote unquote, with the effects of their own traumatic experiences. Personally, as an adult, I didn't identify myself as having been abused or neglected until I was years into my own therapeutic healing journey. So I only then started to recognize how my own trauma had impacted me and also my approach to parenting. Do you find, how would you work with a parent who'd been, through their own trauma and trying to help their child, or is that not something that you would?
Yeah, I think I know where this is going, and it's a wonderful issue to bring up, and one that we encounter, I think, more often than not. Trauma is unfortunately so common, and it's hard enough parenting, right? It's hard enough parenting a child who's experienced. It's even harder parenting a child who's experienced trauma, and it's even harder if you have your own trauma history, as many of us do. And sometimes it's having children that actually triggers your own stuff, and so we see that happening with caregivers too. In the TF-CBT model specifically, we work closely with caregivers, but it's still, at the end of the day, it's a youth-focused treatment. So if we have a sense that this parent has a trauma history or they've been open about that, we would work with them to talk about the possibility of them having their own provider who can do some trauma-focused work with them too. And we all have our blind spots, and so there are times where one hypothesis is that parents own trauma history has sort of numbed them to being more vigilant about trauma symptoms. There's also, parents may not have a great sense for those kids who really are internalizers, because they're not on the radar screen like the externalizer is, who's getting in trouble at school frequently and calls are coming home, or he's getting his attention and they're acting out in that way. It's easier to identify that problem behavior than it is for the child who's more withdrawn and not necessarily on everybody's radar screen, or maybe they're doing great in school, but at home they're keeping to themselves, or they're more avoidant, or that kind of thing. So I think there's a number of reasons why we see that, the difference in parental report, but it is one that's been relatively consistent across our different projects, and one that we're trying to take a closer look at now with a more scientific lens.
Right, and I can also expand on this because it's a pretty interesting phenomenon that we have been observing in our different projects, and we also wondered if there is a specific type of trauma that makes it more difficult maybe for caregivers to be aware of. And we actually saw that in the case of sexual abuse, this gap between the perception of PTSD symptoms between children and parents is higher. And specifically in sexual abuse, caregivers seems to have lower perception of the severity of the PTSD symptoms of their child, which was a very interesting factor to discover. And as I said, this is a current project that we are still working on. But as Jessica said, there are a lot of factors that might contribute to them. First of all, especially in the case of sexual abuse, there is still a lot of shame and guilt around that, so there might be less communication between the caregiver and the child about that, but also a lot of the internalizing symptoms actually of PTSD, such as avoidance or the intrusive symptoms, might be difficult really to capture by the caregiver. But definitely this is something really interesting to look at, and also for some clinical implications. It's really important also for clinicians to know that at the beginning of treatment, it's really important also to assess child symptoms and to consider the child point of view. Very often we refer mainly to the caregivers, but it's really important to take both points of view, and also to know how to provide the appropriate psychoeducation to the parents so that they can be more aware to the symptoms and what the child is going through.
Yeah, and I think just one last thing here in defense of parents, as a mom myself, and it is not the easiest job, as many of you know. It's when we see this minimization of symptoms, or even minimization of trauma experiences, they're denying that trauma even happened or that it's not as bad. It is also a very normal and natural phenomenon, in that if you think about it, if you know that something awful has happened to your child, your very first reaction is to say, please, God, tell me this is not true, right? So denial is very protective in that way. And so that I also wonder about that minimization too, that it's really hard to take that on, that, gee, my child has experienced this and they're in so much pain, and that's very hard for parents to grapple with initially. So I think we see a lot of that, especially in our earlier assessments, because later those differences between parent and child reports get better. So I'm wondering if there's something about that. So we're trying to take a closer look into that particular research question.
Thank you. So you may have answered this earlier, but I just wanted to reiterate again. Does TF-CBT allow cultural enhancements?
Yes, absolutely. Great question. TF-CBT has been conducted all over the world, and with each of those implementations, there's been cultural modifications that happen. So just very quickly here, because I know we're running short on time, but in the Democratic Republic of Congo or Zambia studies, for example, they're actually training non-mental health providers, NGO, non-government organization folks, but they're not mental health providers. They're training these paraprofessionals to go in and do the TF-CBT work, but they're partnering with ambassadors in different villages and doing these culturally modified implementation of the treatment based on what works for that particular population or group. So there are ways in which we modify TF-CBT, working with military families, for example, Native American families, and in different settings too. TF-CBT in the school system may look different than TF-CBT in an inpatient or residential setting. And so one of the beauties of the model is that there is a lot of flexibility, and sometimes you don't get that from a traditional evidence-based practice, but there's a lot of ways in which the model is able to be flexible while still maintaining overall fidelity to what you're trying to do.
Well, thank you so much, Dr. Griffin and Dr. Kosova. We really appreciate you taking the time to do this great webinar. The slides and the recording from today will be made available on iSpark's website. Take a look for them later next week. And then please, if you haven't, join our listserv so that you'll be notified about upcoming webinars and other events, new products that will be coming out. We, publish short 2 to 4 page briefs or tip sheets for a bunch of, for parents, for providers, for young adults. And well, thank you so much, and have a great afternoon, everyone.
Thanks, everyone. Feel free to reach out anytime.
Thank you.